This isn't to protect against abrasion in this place. There are some places in the digestive tract where we have that, specifically in the mouth, in the oral cavity, and in the anal canal. In those areas, we have stratified squamous epithelium, and that's because that's always being abraded and rubbed. But to my knowledge, everywhere else in the digestive tract, it's simple columnar.
In esophagus?
What's it?
What in esophagus? Squamous.
It's a good question. Yeah, no, you're right. The esophagus is non-keratinized, it's stratified squamous. Yeah. Mouth, esophagus, and anal canal. Yeah. Everywhere else, I believe, is simple columnar. And then this part up here. So we secrete mucus. We're going to get to the digestive enzymes and hormones a little bit later. So right now I'm just going to leave that alone. We're going to have several glands that are called unicellular glands. Glands that actually secrete substances, but it's only a single cell instead of a larger multicellular gland. Okay? And so those epithelial cells will frequently secrete hormones or digestive enzymes. And we'll talk about those in a little bit. Everything I just said. I don't really want to tell you, there's nothing you got to worry about remembering about the lamina propria. I really don't want to emphasize that at all. Into the submucosa, I think we went over that a little bit. So I mentioned the submucosa's main job is to hold it, so it's this loose connective tissue. It holds the blood supply, it holds lymphatic vessels, it holds the nerve supply. So here's the first time I'm going to introduce this idea. The nerves of the digestive tract, in general, are called the enteric plexus. The nerves of the digestive tract are called the enteric plexus. And these are autonomic nerves. And they have ganglia associated with them. If you remember studying the autonomic nervous system at all, you might remember that there's two divisions, right? Sympathetic and parasympathetic. The parasympathetic nervous system had that characteristic of having those things called terminal ganglia, which were these collections of cell bodies that are actually in the walls of the organs themselves. That's how they're defined. So, in the enteric plexus, that's what we find. We find terminal ganglia of the parasympathetic ANS. And they're connected to an extensive both sensory network and motor output network. The motor output network, the enteric plexus, pretty much innervates glands and smooth muscle. And the sensory component contains things like pain sensors and stretch receptors. But they all feed entirely into the enteric network. So we have a lot of what's called enteric reflexes. Which just means that if I stretch a part of the gut, that enteric nerve network will sense the stretching, feed it into those terminal ganglia, and then the terminal ganglia will send out a response telling that part of the intestines to contract a little bit. So it's reflexive. So in other words, peristalsis and things like that will continue without any input from the brain. Okay. It'll become very sluggish, and it won't go like we'd expect it to because it's not being regulated by the brain if, say, the brainstem is destroyed. But it will still happen reflexively. It's called an enteric reflex. Okay. And we'll talk more about that. I just want to introduce that here. We mentioned a nerve plexus. That would be the enteric plexus.
Enteric with an E.
E-N-T-E-R-I-C. Enteric. That's generic for intestines, whenever you see that. All right, then we get to the muscularis externa. As I mentioned, the main thing it does is peristalsis. Move the food along. Okay. There are areas where we'll come to thickened layers, and those are sphincters. I can think of 1, 2, 3, 4, 5 sphincters that we've named. Okay, let's see if we can go over them. See who remembers them. You want to throw one out there?
Lower esophageal sphincter.
We got a pyloric sphincter. I heard that one.
Esophageal sphincter.
Lower esophageal.
Okay, upper and lower esophageal sphincters, upper and lower, which could also be called the pharyngeal and cardiac sphincters. What's that? What's that?
Lower.
Well, that's not what we talked about, though. All right. So let's say I heard. All right. So we'll go in order. The first one you would come to would be the upper pharyngeal, which is also called the upper esophageal, which is also called the pharyngeal sphincter. And we'd swallow the food down the esophagus, and we'd have to go through what's called the lower esophageal sphincter, or that would be the cardiac sphincter. We go to the stomach.
Pyloric.
We go through the pyloric sphincter. Okay. Now here's the one that I didn't expect anybody to remember.
Ileus.
That's a lot later.
That's
So
later.
while we're in the duodenum, we encounter another one. Not that we have to pass through it, but we have the sphincter that controls the opening of the hepatopancreatic duct. And that's called the sphincter of Oddi.
Oh, sphincter.
Could be the hepatopancreatic sphincter or the sphincter of Oddi. And I only mention that detail, guys, because that one actually causes some significant clinical problems. Okay? If the sphincter of Oddi or the hepatopancreatic sphincter, same thing, fails to open, then all that biliary and pancreatic secretion can't get into the duodenum. Okay? And that can cause severe gastrocolic problems. Okay? In babies is where it's usually manifest because they're throwing up all the time and they're cranky and they're failing to thrive and they're not digesting their food properly, and it's hard to diagnose, you know. So once they've gone through all their clinical assessments, they might get down to thinking it's that, and then they have to actually put a barometer in there on an endoscope, and they put a pressure gauge into that sphincter, and they record the pressure behind it to see, because they know what it should open at, and if the pressure's too high, then it's not opening. So you're not getting bile, and you're not getting pancreatic secretions into the intestine. You can't digest pretty much anything when it's like that. So it manifests with a lot of pain, a lot of swelling. You get swelling of the gallbladder or the pancreas, or you get pancreatitis. You can get hepatitis because of that, and it could kill you, actually. The treatment for it's pretty simple. They just have a surgery where they go in there and I don't know if they use a laser or if they actually cut it, but they just kind of cut the sphincter a little bit, loosen it up so the secretions can get into the intestine. So that's one that has some clinical ramifications. All right, so then now we're in the duodenum, and then from here, yeah, we go through the duodenum, the jejunum, and the ileum, and there's nothing in the way. And then we got the last one, we said the ileocecal junction and the ileocecal sphincter. That should be fine. Okay. And then, yes, the anal sphincter, that would be another one. When you get down to the end of the rectum, there are two sphincters. There's an internal and external anal sphincter. The internal one is smooth muscle, the external is skeletal muscle. I think I went over this before, didn't I?
Mm-hmm.
So the internal one opens reflexively when the rectal vault is full, and then you have conscious control over the external one. All right, so sphincters are our friends.
Sphincters are
Okay, so as I was mentioned before, if you come off of the visceral peritoneum, that's when it gets called adventitia. That's what the serosa is called. That's just the definition. Nothing else to say about that. Picture, enteric plexus. Don't worry about delineating the enteric plexus into the submucosal nerve plexus and the myenteric plexus. Don't worry about it. You should probably recognize the root for myo means muscle. So not surprisingly that myenteric means my means muscle. So that's the smooth muscle control, and this is glands. But like I said, I'm not going to ask you to delineate between the two. I'm going to skip the reflex right now. I'm going to talk about that a little bit later. So, this looks like our sagittal head section. Okay, what we had in mind. So if I asked you to identify the oral cavity, you can do that, right? Oral cavity goes from the teeth posterior to the opening of the oropharynx. That's all oral cavity there. And the tongue takes up most of the oral cavity. Okay. So you come back over the tongue, and we come posteriorly here, and then we run into this bumpy patch right there, and that's our lingual tonsil. And over here are our pharyngeal tonsils, and out of the picture, but up here would be palatine.
Right.
Lingual, palatine, and up here would be the pharyngeal tonsils. So could you identify all those in the sagittal head section? Without too much trouble? Then the pharynx, and I know, well, she's not here, she had to leave. Somebody asked me about this in lab today. Remember, the pharynx is just a muscular tube. That's all pharynx means. It means muscular tube. It has three parts. The superior part of the pharynx is called the nasopharynx, and that's up here. We'll talk a little bit more about what goes on in the nasopharynx when we do the respiratory system. Right now we're talking about digestion, so what we're concerned with is the oropharynx, which is right here, and that extends superiorly from the uvula and inferiorly down here to the epiglottis. Okay, so that's the oropharynx. And then the laryngopharynx is this pouch right here. The stuff shown in blue here, that's supposed to be hyaline cartilage with some ligaments attached. So this is actually your larynx. Anybody know what the larynx is also called? What we commonly call it? Voice box. Yeah. So this is the top of your trachea. If you reach up here and you touch that, you're touching your larynx. Okay? So behind that is the esophagus. The esophagus is posterior to the trachea and larynx, which is kind of a design flaw. If you could work out a way to do it, I guess you'd prefer to have the digestive tract not pass posterior to the respiratory tract, because that causes a lot of problems. When we swallow anything, it's got to go over your respiratory tract to get into the esophagus. So that sets the stage for choking, right? And what we call aspiration. When you send things down your windpipe, we call that, I've aspirated it. Usually it happens with liquids, not solids, not too often, but much more common with liquids. So that cartilage flap right there is the epiglottis. Okay, everybody know why it's called the epiglottis? I mentioned it in class, but see who remembers. Well, glottis is just right. And glottis means mouth or opening. So the glottis is the opening to the trachea. So this cartilage is called the epiglottis because it's above that opening. That's why it's called that. Okay. Right. So the idea here is when you swallow. Pardon me. The muscular tube of the pharynx squishes the food back here, and in so doing, it causes that epiglottis to fold backwards down over the trachea and cover that opening. So then the food slides over the epiglottis down into the esophagus, preventing aspiration. Now, if you're hiccuping or laughing or trying to talk at the same time, air is being pushed out through the trachea, and that causes the epiglottis to open. And so that causes problems. If you hiccup or giggle or laugh while you're trying to swallow, you're likely to confuse this, get stuck halfway, and then something slips into the trachea. Okay? And you get the food down there, and then that hurts like crazy, and you cough and spasm and all that.
How does it go from there and out your nose?
Okay, something else is, so when you swallow, what's supposed to happen, and we'll talk about swallowing here in a minute, but when you swallow, the nasopharynx constricts and raises the uvula up here and closes the opening to the nasopharynx. Similarly, the epiglottis folds over the trachea and closes that. So both of those passages should be closed when you swallow. Okay? But like I said, if you're laughing, then this lowers because you're trying to do respiration, and that can shoot the milk right out your nose. Okay? Not a fun feeling. So in the mouth, we know what happens in the mouth is we do mechanical digestion, right? You chew up the food, you pulverize it with the teeth, you liquefy it, you mix it with saliva. And we actually even start a little bit of chemical digestion in the mouth too, but I'll wait and talk about that a little bit later. Once that food is pulverized and liquefied, we call it a bolus, B-O-L-U-S. Once it's, kind of a gummy wad, we call that a bolus. So what you swallow isn't a chicken leg, it's a bolus of food, okay? So that bolus is then pushed back here. Swallowing can be split into two phases, and there's some pictures that show this later. But swallowing can be split into two phases. One is called the voluntary phase, and the other one is the involuntary phase of swallowing. Okay. The voluntary phase is also called the oral phase. It's what happens in your oral cavity. And this is where you're chewing the food, and you consciously push it to the back of your mouth with your tongue. Your tongue pushes the food back there. And that's all voluntary. Now, once the food gets back here, it stretches the musculature of the pharynx. And in response to that stretching, it contracts. And so this part, called the pharyngeal phase, is involuntary when you swallow. As an aside, this is the only place in the body where skeletal muscle is under involuntary control. These pharyngeal constrictor muscles are skeletal muscles, but they contract reflexively. So it's the only place in the body where you have skeletal muscle under involuntary.